This is a general disclaimer. Redlands Community College attempts to have the most accurate and up-to-date information listed in its content and delivery. However, your education is your responsibility. Redlands Community College or Roy Smith makes no guarantee in the accuracy of this information in this video and accepts no liability for the informational video. The information expressed is strictly the opinion of the author and the presenter, which is listed in the reference near the end of the video. This information is designed to supplement your own education or initial education and should not be used to replace any current academic program you're enrolled in. View the information and content at your own risk. Thank you.
This is going to be Chapter 6, Errors of Conduction, Bradycardia, and Key Concepts. After completion of this chapter, you'll be able to understand reentry as an etiology for dysrhythmias, conduction abnormalities as an etiology for dysrhythmias, given an EKG strip in either lead 2 or MCL1, identification of dysrhythmias caused by reentry or conduction abnormalities. Chief concern whenever we're looking at bradycardias is going to be syncope, which is a brief sudden loss of consciousness and postural tone. Almost spontaneous revival represents a disturbance in brain function, and the reason being is because the cardiac output gets so low that it doesn't perfuse the brain enough. Cardiogenic syncope, ventricular diastolic disorders, dysrhythmias, outflow obstructions. The principal cause of syncope from cardiogenic syncope is dysrhythmias. Now, you can get syncope from other sources. Let's talk about that for just a second. You'll see this more in medical emergencies, but if they have an alteration in electrolyte disturbance or electrolytes, or they have low amounts of blood sugar, that could also give you syncope. So spread your net wide, start your assessment, find your clinical indications, and then go with your field impression. Sinus bradycardia can occur a result from, and most of the time, age-related conduction system changes. Medications can also pose a problem as well. Things like digitalis, beta blockers, calcium channel blockers. They could have taken too much of them, or they didn't get an appropriate amount of elimination from their body, and they had a toxic buildup. Sudden drop in heart rate resulting in syncope. This is often due to things like hypersensitivity of the carotid sinus syndrome, neurocardiogenic syncope, my apologies, and this is caused from cardiac inhibitory portions of your own physiology or vasodepressor effects on the body, which would cause vasovagal reactions or vasodilation. And then sick sinus syndrome. Sick sinus syndrome we'll talk about here on the next slide as well. So, sick sinus syndrome can cause a profound bradycardia. Causes of this is kind of natural fibrosis of the SA node that occurs with aging. Pathological condition, acute myocardial infarctions could have got you there. Subsequent ischemia of the SA node, Lyme's disease, or any kind of other infiltrative diseases of the area. Medications, anti-dysrhythmic medications, specifically procainamide, verapamil, diltiazem, and amiodarone. The Von Williams classifications will get you there pretty quickly. A class 1. This is from pharmacology if you need a review. Class 1 is a sodium channel blocker. Class 2 is a beta blocker. Class 3 is a potassium blocker, and a class 4 is a calcium channel blocker. So any of those can definitely get you into bradycardia when looking at medications. Symptoms of this are going to be marked bradycardia. So the bradycardia, you're going to have a slow heart rate, and you could possibly even have a syncopal episode. EKG shows a slow sinus rhythm. Patient may complain of lightheadedness prior to the event, difficulty breathing, chest pain, and/or palpitations. Conduction blocks, heart blocks, and penumbra. Talk about a multitude of things here. So conduction blocks, things like the sinoatrial node or the atrioventricular node. So if we're looking at blocks either from age, deterioration of the SAAV node, or from an active infarct that might have affected it. Either one of these are blocked, we're going to have conduction disturbances. Heart blocks in the penumbra. Type 1 heart blocks are supernodal. Supernodal blocks, or type 1 blocks, should not be confused with AV nodal blocks. The type 1 blocks that are supernodal is speaking of, it occurs from a vaso-occlusive event of the right coronary artery, and it involves the inferior wall and the AV node. Now, the heart's kind of set in the body with the apex out here, and the whole back of it is considered the inferior wall. Well, that's what feeds the conduction system. So that is primarily fed from the right coronary artery. So if we get any type of that causes bradycardias or any kind of dysrhythmias, it's considered a supernodal block. If we have type 2 heart blocks, infranodal, it generally occurs from the left coronary artery feed on the septum. So we have, and let's just go to the whiteboard here for a second, draw it a little bigger so we can see it. We have a heart, and this is the semilunar valve on the left ventricle. It has 2 openings, one for the right coronary artery, and this kind of loops around the back. And then we have a left main, an LAD, and then a circumflex that kind of loops around the back as well. Now, this LAD feeds the septal and anterior sections of the heart. So one of its branches feeds the septal area where the conduction system also is housed. This can cause an infranodal block. An occlusion, a vaso-occlusive event in the left coronary artery that supplies blood to the sternum, is a type 2. Okay, the dangers of heart blocks are very simple. You can go into complete heart block or have AV disassociation. A 3rd degree block is a complete heart block. So here are the structures that we're looking at. We'll just do a quick overview. You can go back and review 12 lead, or you can go back and review basic EKG. AV node. At the AV node level, we have the bundle of His, which doesn't know what it wants to do with its life. This is the right bundle branch, left anterior and left posterior fascicles. We have 3 fascicles in the ventricles. Trifascicular. History, we should always consider their symptoms. Were they lightheaded, dizzy? Were they having chest pain, shortness of breath? Or did they have signs and symptoms of heart failure? If they're taking medication, many medication, particularly those in the Von Williams classifications, can cause bradycardias if overdosed or if they're in toxic levels. Beta-adrenergic blockers and digitalis have effects on both the ventricular mass and decreasing contractility and diminishing blood pressure, so be aware of that. As far as thyroid hormone levels, if they have low thyroid hormone levels or they're in hypothyroidism, this can lead to bradycardia. Pacemakers, without a properly functioning pacemaker, the underlying or native rhythm is going to show its face. So they could have been in complete heart block that got them the pacemaker to begin with. If their pacemaker fails, they're going to be in complete heart block. Examination. Presence of bradycardia. A potential heart block, where it be a high degree heart block or a complete heart block, should be identified. Regular pulse within normal limits. This could possibly be a 1st degree heart block. If it's slow and irregular, probably a 2nd degree heart block. The identification of a 2nd degree heart block more P waves than QRSs. This is going to be a 2nd degree type 2. And this one's going to skip. So a slowly progressive PR interval until we drop a beat. This is going to be a 2nd degree type 1. This one here is considered a high-degree heart block. The other cousin that it has is considered a high-degree heart block as a third-degree AV block. So, EKG findings, patients with chest pain, shortness of breath, etc., and this would be all of our chest pain symptoms: diaphoresis, chest pain, shortness of breath, radiating, nothing makes it better or worse. Place them on a cardiac monitor, assess for a heart block. Lead 2 is the best choice. The reason lead 2 is the best choice is because it looks at the entire conduction system, and it looks at the appropriate angle. Negative electrode. So we're going to see the heart block the best by something that's looking at the entire picture. Benign causes may have no outward manifestation of the AV block whatsoever. And just very simply, we can have no symptoms whatsoever and a person be in a heart block. We're going to treat them symptomatically. Sinus disorders occurs when an impulse is blocked in the atria or there's an error in conduction. When the SA node fails to fire, there's an error in automaticity. Sinus rhythms with type 1 AV heart block, and this would be type 1 block, remember, is supranodal versus infranodal, and this is vasoocclusive of the right coronary artery. So sinus rhythm with a type 1 first degree AV block. The sinus rhythm with a type 1 AV block can be benign as a result of fibrotic changes associated with old age or pathology, or as a result if they had an acute coronary event. So first degree AV block, PR interval greater than 0.20. A second degree block, which is lengthening PR intervals until you drop a beat, or a third degree AV block. And that would be absolute disassociation between the SA and AV nodes, or there wouldn't be any association between the atria and the ventricles. Type 2 blocks. Now type 2 blocks are infranodal. This is probably the distal areas or the areas that feed the septum on a left coronary artery. And in a type 2 block, they're an infranodal block. That involves a bundle of His in the bundle branches. It may also occur as a result of an acute coronary event or an MI. Again, first degree AV block identified by a PR interval greater than 0.20. Sinus rhythm type 2 with a second degree AV block. And that would be slowly, progressively PR interval until you drop a beat. And then a sinus rhythm with a type 2 or third degree AV block would be no communication between the atria and the ventricles. Heart transplants. About 3,500 transplants occur annually. Now, whenever they transplant a heart, it becomes denervated. So your heart normally has parasympathetic nerve attached to it, but at the point that they put somebody else's heart in there, very simply, they don't reattach that nerve. So these hearts are denervated, so atropine may not be effective at all on the bradycardias. Common procedure for transplants: remove the native heart at the mid-atrial level and replace it with the donor heart. And there's a high risk for conduction abnormalities whenever this occurs. So the first thing we do in the assessment is and this is off a predictated treatment, is the patient symptomatic or asymptomatic? Now there's a couple examples here. Let's say that you have a heart rate of 50 and you have chest pain, shortness of breath, and diaphoresis. Well, you are symptomatic. But let's say you're an Olympic athlete with a heart rate of 40 and you have good blood pressure, 110, 120 over 70, no chest pain, no shortness of breath, and feel fine. That would be asymptomatic. If you had a syncopal episode and those indications, you would have to determine if there's another clinical path, or, very simply, if that bradycardia got that patient to that point. History is how we obtain this. Signs of hemodynamic instability, signs of hypoperfusion, dizziness, syncope, chest discomfort, shortness of breath should all set off alarms for us. Treatment. Parasympathetic stimulation, if the patient in their history had persistent vomiting, if they had an infection or possible toxins developed, or they haven't had a bowel movement, they might have a small bowel obstruction. Medications like beta-adrenergic blocker, they may have taken 2 of their medications because they missed a dose and accidentally overdosed on beta blockers. Or same way with the calcium channel blockers. They may have accidentally or inadvertently overdosed with those as well. Hypothermia, they're ice cold on the inside. Increased intracranial pressure. Now this right here is kind of a special topic. We're not going to provide any treatment of the bradycardia unless they're hypotensive. So what I mean by that is if you have a traumatic brain injury and the person has a head bleed and their blood pressure is 180 over 110 and their heart rate is 40, you will not need to apply atropine or transcutaneous pacing to this individual. Get them to a center that can put in a bolt, essentially, to drain the bleeding. And then pain. Was the pain, did it cause a vasovagal response, and is it just temporary or paroxysmal in nature, or is it consistent? Transcutaneous pacing. A transcutaneous external pacemaker, as far as the features go, we essentially place pads, the same place we would place the quick combo pads, or do an anterior-posterior application, if we're just going to transcutaneously pace them, and take over the patient's pacemaker sites from the outside of their chest. Now there's a couple different modes. There's synchronous and asynchronous mode. Asynchronous is a fixed mode, so if we go into asynchronous mode, whatever we set that pacemaker at, that's what it's going to perform. It's not going to take into consideration anything that the patient's doing. And there's synchronous mode, which is essentially also called demand mode, which the pacer senses the QRS and will let the patient go ahead and have their own beats. It just makes up for the deficiencies in the overall rate. As far as capturing, there needs to be two forms of capturing. You need to see a spike followed by a wide QRS, and that would be electrical capturing. And then you need to have mechanical capturing, which would be an associated central pulse. In special cases, we may override a patient with tachycardia. We need to obtain capture, go over what their heart rate was whenever we attain capture, and then back it back down. These are classifications for transcutaneous pacing and where transcutaneous pacing may be useful. So a class 1 has usefulness, symptomatic complete heart block, symptomatic bradycardia, second degree AV block type 1 or type 2, a type 2 second degree AV block with cardiac concerns, or a type 1 second degree heart block with type 2 first degree heart block. So they also have an increased PR interval along with the slowly progressive PR interval. Even their baseline, their initial one that should be fairly normal, is greater than 0.20. It may be useful as well in class 2s. Asymptomatic complete heart block with ventricular response greater than 40 beats per minute. A type 1 second degree with cardiac concerns as well. Not useful in first degree AV blocks. A type 1 second degree AV block or Winky block. A type 2 first degree AV block with the bundle branch block. Now, this is a progressive thing when we look at the American Heart Association standards, and I would look in your algorithms. If you have attempted, if it's not a high degree heart block and you have attempted atropine, your next progressive step would be to go to transcutaneous pacing. Just keep into consideration your patient may improve or they may not, depending on what type of initial rhythm that they were in. Steps in pacing procedure. I kind of disagree with these two, and I'll talk about this here in just a second. We must maintain their airway, maintain adequate ventilations and circulation. We should provide venous access as well. Spread our neck because things could go south. We need to get an express consent on the transcutaneous pacing before we add any sedatives. So I believe that this should go here. Evaluation. Important concepts. Ventricular pacemakers. Now this is if the patient has their own pacemaker. So an evaluation of this. Is the ventricular pacemaker capturing? Is it appropriately sending a spike followed by a wide QRS, and does my patient have a pulse with that? Do I have a dual-chambered pacemaker? A dual-chambered pacemaker would be an AV sequential. And are they both capturing? Generally speaking, when they put somebody on an AV sequential is because they still need their atrial kick for cardiac output. If they have an atrial pacemaker, they could have just had sick sinus syndrome as a youth, or younger than instead of age-related symptoms. Pacemaker construction. Pacemaker construction is pretty simple. Internal pacemakers consist of a pulse generator, an electrical circuit board with resistors and capacitors, a microprocessor, and a reed switch. Weak points on them. Original pacemakers had unipolar leads. Original internal pacemakers used a mercury zinc battery. All of this is upgraded on the new generation pacemakers, so depending on how old the pacemaker is, the pacemaker itself may be more improved. Categories as far as pacemakers go, they're going to be ventricular pacemakers, atrial pacemakers, and then dual chamber. Now the dual chamber, even progressively, this has changed as well. So they have both AV sequential and biventricular. Biventricular is if the patient has had an MI in the septal area and that the lead here in the right ventricle won't be able to depolarize the entire ventricles. So they essentially go in and loop it around through the venous side or the return port and fire off over here from the left ventricular side. So they have biventricular pacemakers. Any kind of MI in this area here, and there wouldn't be a conduction pathway. Pacemaker syndromes. Physiological impacts of pacemaker. They have a loss of atrial kick, especially if they only have a ventricular pacemaker. Cannon waves, pulsations in the neck and chest. If we transcutaneously pace them, this is a ventricular pacemaker, so they're going to have this as well. Cannon waves in the neck and chest as atria contract against closed AV valves. Increased atrial back pressure leads to pulmonary hypertension and venous congestion. Consequences on this are going to be atrial fibrillation and heart failure. The symptoms they can get from pacemaker syndrome: dizziness and confusion, shortness of breath from loss of cardiac output, paroxysmal nocturnal dyspnea, fatigue, and then signs of shock. Pacemaker malfunction. Pacemakers malfunction for a pretty minimal list here. It failed to discharge for whatever reason, it failed to capture for whatever reason, and it failed to sense for whatever reason. And you can also get some oversensing problems, that it failed because it's sensing everything. Symptoms on this, if they have pacemaker malfunction, are going to be things like syncope, the patient just is going to lose cardiac output, palpitations in their chest, and bradycardia. Procedures in the case of malfunction: obtain the most recent program code, obtain the date when the pacemaker was inserted, ask the patient to provide her resting heart rate, obtain an EKG, preferably in lead 2, and assess the underlying native rhythm, and assess for capture. Percussion pacing can be performed as well, and this is kind of like manual pacing, performed by applying sharp blows to the chest in the same manner as a precordial thump, but with 1/4 of the force. There's also chemical pacing, pacing with dopamine or epinephrine. We're going to directly talk to the tissue. And then in special cases of overdose, let's say that the patient overdosed with beta blockers, we could provide them with a glucagon infusion. Glucagon is the antidote for beta blocker overdose. Implantable cardioverting defibrillators. Next generation of pacemakers detects and terminates a tachydysrhythmia upon seeing it. Also aborts SVTs and VTAC as well as VFib. So it senses what the rhythm is doing and applies a shock at much less joules than we have to, and hopefully will convert the rhythm. Disposition. Where do we take these patients to? Bradycardia secondary to AV block. Transport them to a cardiac center. As far as documentation, please complete any pacemaker history that you have. the percentage of the time the pacemaker was pacing, and transcutaneous pacing, if you're transcutaneously pacing the patient, electrical and mechanical capture assessment, be sure you have a spike followed by a wide QRS and an associated central pulse, and pace rate and energy use in milliamps. So go over the skill set of transcutaneous pacing in the skill section and Schoology for this section, and go over the algorithms on how to treat bradycardias. Both are going to be important for this section. This is just to cover what's in the book to help you with some of the homework. In conclusion, errors in conduction producing bradydysrhythmias can present subtly. Range, feeling fatigued, hypotension, altered mental status. 12 lead is essential if you can get one. A paced rhythm is going to look like 12 leads of paced rhythm, but it is an important part of assessment. For references for this chapter were taken from Myers, Professional Paramedic, Volume 2, Medical Emergencies, Maternal Health and Pediatrics, Delmar Learning. And if you have any questions covering this section or in this section, feel free to give me a call. My name is Roy Smith, smithr@imsa.net, or 405-219-7613. Thank you.